So let's have a great day and let's get started with our program. So our first speaker to start the day off is Dr. James Nimitz. He's the president and my boss at the West Virginia School of Osteopathic Medicine. And the word that I always say when people ask about Dr. Nimitz is integrity. I've never worked with anybody with this level of integrity, and I'm so very appreciative. So I'm anxious to hear his information that he's going to share with us. Dr. Nimitz.
Good morning, everyone. Welcome to day 2 of the Small Communities Big Solutions Conference. The focus is on healthcare, so important to the growth of our state. And what I want to do today is spend a few minutes just telling you about my institution, the West Virginia School of Osteopathic Medicine, and what we're doing to improve health for West Virginians. So we'll get started here. I'll share my screen. Okay, so I want to start off with this beautiful video of our main campus. WVSOM's main campus is located in the beautiful Greenbrier Valley in Lewisburg, West Virginia. And if you haven't visited us, I encourage you. I have an open invitation to come and visit us and see what we're doing here in Lewisburg. We're so proud of the work that we do for the state. Here's our mission, and the thing I want to point out about our mission is towards the end, where we say WVSOM is dedicated to serve first and foremost the state of West Virginia and the healthcare needs of its residents, emphasizing primary care in rural areas. You know, when the school was founded a little less than 50 years ago, there was a real problem in the state. There weren't enough physicians in rural West Virginia, and there were 4 visionary DOs, Dr. Apgar in Huntington, Dr. Wallington in Wheeling, Dr. Newell in the Oak Hill area, and Dr. Bales in the Princeton Bluefield area. And they saw this need. And so when the Greenbrier Military School closed its doors, they purchased the campus here in Lewisburg, and they created the Osteopathic Medical School, really against a lot of challenges. And you know, for the whole purpose of serving West Virginia and serving particularly the rural areas of West Virginia. So almost 50 years later, actually in 2022 will be our 50th anniversary, and we'll have a big celebration that you'll hear about next year. We're the #1 school in West Virginia, the Appalachian region, at the nation, and some people even say the world. The world piece is not documented, but the others are documented by third-party sources. We're the #1 for rural placement. So in the state, Appalachian region, and the nation, we're the #1 for graduating physicians who practice in rural areas. And we're really proud of that. I mean, the vision of our founders 50 years ago has been realized, and we're so proud of that. We lead in the state for the production of primary care physicians, which are so very much needed in our healthcare system. And as I said, we lead in physicians in rural areas. In addition to that, we've been recognized by U.S. News and World Report for over 20 years. And our employees consider WVSOM to be a great place to work for. But the other point I want to make is that we have a big economic impact on the state, $133.6 million per year. And I'll talk a little bit more about that in a few minutes. I mean, realize that all of your institutions of higher education are economic engines for the communities that they're in. So in terms of our alums, we're still a relatively young school. And the other thing that's interesting and unusual about WVSOM is we're a standalone medical school. We're unto ourselves. We're not attached to any other institution. We have our own board of governors, and we are part of the state system of higher education, overseen by Higher Education Policy Commission. We've produced a little over 4,000 graduates, and almost 1,000 of them are here in West Virginia. You can see that we populate the majority of the state. I mean, our footprint in West Virginia is all over West Virginia because we populate all the rural areas of West Virginia. We're in 51 of 55 of our counties. And then nationwide, we're also a leader in rural healthcare, and we're in every single state in the union. I think, you know, the reasons for our success are many, but certainly I believe that it's how we educate our students that is really a key component of our success. So for the first 2 years of their medical school experience, our students are here in Lewisburg on our beautiful campus. Again, come and visit us. We have 73 acres here, and our facilities are top notch. We use a patient presentation curriculum, and I think this is a great curriculum because it's focused on the patients. I tell students all the time that it's all about the patient. And so in this type of curriculum, they're actually learning everything like their biomedical sciences, like anatomy and physiology and biochemistry within a clinical context, within cases that they'll see, patients that they'll see in their careers. Yeah, as you can see, we heavily use technology. This is a pre-COVID image. And we've done very well during COVID, and you know, things have been modified, but we're in person and things are going well, and we're very thankful for that. And we're also almost 99% vaccinated. So we're proud of our students and our faculty and staff. We also have a state-of-the-art accreditation center. It's really an incredible facility. It's one of the best in the country. And it's amazing what you can do with simulation. You know, you can simulate just about any type of medical issue, and including things like domestic violence or child abuse or substance use disorder. So it's a great tool. We also involve other institutions so that we can do interdisciplinary education in our center, which is accredited both for education and for assessment. I think one of the key things is our statewide campus. So even when we had a class size of 65, we could not train all of our students in the Lewisburg area. So what we've done is we send our students out in the 3rd and 4th year all over the state. We've divided the state into 7 statewide campus regions, and we have physical presence, in other words, offices and staff in all of these regions. The numbers that you can see are indications of where the hospitals and clinics that our students train in. We're the largest medical school in the state. We have over 200 students per year with a total of over 800 students. But I think this is a big part of our success. We, of course, we've developed collaborations with pretty much all the hospital systems in West Virginia. And, you know, we're very thankful for our relationships and our collaborations with WVU Medicine, Mountain Health Network, CAMC, Mon General, and so forth. Like I said, we're involved in 61 total sites in the state, hospitals and clinics. You know, we're stronger when we work together, and I think our model demonstrates that. It benefits these institutions. Our students are providing over 1 million healthcare hours a year, and we serve. Basically, our students are serving, and then of course our preceptors are involved, and our own employees. We also have, as a result, an economic impact across the entire state. And here you can see a recent economic impact study that we did. And because of our statewide campus, we contribute to the economy of communities all over West Virginia. And then when you add the impact, the economic impact of our graduates, it's over 1.5 billion. So we're contributing to West Virginia's economy, and we're very proud to do that. We work with many hospitals because the next step after graduating, after 4 years of medical school, our students go on to residencies. We work with the hospitals in terms of graduate medical education. Realize that there's a need for more residencies in our state, so we can continue to increase the number of physicians in West Virginia. We do have a modest research enterprise. We involve students, and we also, again, collaborate with partners around the state, WVU, School of Medicine with the West Virginia CTSI, and Marsh with the Embry Grant. And then finally, I want to say we're very involved in the community. Community engagement is something that we do extremely well, and it's something that, I tell people all the time, a medical school should do more than just graduate great, caring, competent physicians that care for people in our communities, but also we should be educating people how to be healthier. So this is our Klingman Center, which is located in downtown Lewisburg. Come and visit us. It's located in Montwell Commons. There's Gwen Klingman, who it's named after, an incredible woman. And we're teaching people how to address their chronic diseases with lifestyle change, teaching people how to grow food, how to cook food, and how to manage their chronic illnesses. We also have been at the forefront of opioid education, and we've produced toolkits for the entire state. Many of them are county specific, and we're proud of that work, and we will continue to work to help with people who are in, who have substance use disorder, trying to prevent the disease, but also trying to help people who are in recovery. So thank you very much. We really appreciate all of our presenters today. We have a great lineup of speakers for you today. So I'll now turn it back over to Dr. Hill, who will continue with the program. Thank you. Bye now.
Thank you so much, Dr. Nimitz. Okay, so our next speaker really doesn't need an introduction, but he really doesn't. So he is, West Virginia's coronavirus czar. He's vice president and executive dean for health sciences at WVU, but also just a good guy that we all like and who talks to us in a way that we can all understand what he's talking about, which doesn't always happen with people at his level, but we appreciate that he's here with us today. And so I'll turn it over to Dr. Clay Marsh.
Thank you, Drema. That's much appreciated. If I can ask you to perhaps help me if there are questions put in the chat. And what I'd like to do for my time in talking with the group would be to make sure that if there's questions that come up, please ask them, and I'll stop what I'm talking about and we'll address what people want addressed. And if you can give me also the 5-minute sign before I'm ready to be done, that would be great, and I'll wrap it up. So let's just talk a bit about COVID-19 in West Virginia and where we are, where we've been, and maybe where we're going. So where we are today is we have just passed a very serious surge of COVID-19. And this has really been driven mainly by the new variant of COVID-19 that is basically the only variant that we're dealing with right now in West Virginia, which is the Delta variant of COVID-19. And just as a reminder, the World Health Organization decided, because of the potential stigma that would be associated with a country where a different variant, and just again, reminder, a variant is just the COVID-19 virus that's had enough replication mistakes. When it multiplies, it makes genetic mistakes, and those genetic mistakes are called mutations. And as the mutations add up, most of them don't really impact the virus one way or another, so we don't pay much attention to them. But every once in a while, a series of mutations or changes will give the virus a beneficial advantage, and therefore we call that a variant. And the Delta variant was the variant that started in the country of India. And as a reminder, in the country of India, which is about 1.3 billion people, pre the Delta variant starting in India, they did antibody testing on a good part of their population. They had about a 27% positive population. 10 to 12 weeks later, they counted 400,000 deaths. Outside epidemiologists from very reputable places basically thought that India suffered about 3.5 to 5 million deaths during that 10 to 12 week period. And when they did a seropositive rate, they did an antibody rate at the end of that period, it was then 81%. So their basic infected population went from the low 20% to over 80% in a period of 10 to 12 weeks. This variant is by far the most infectious variant we've seen during COVID-19. And Rochelle Walensky, who used to be the head of infectious disease at Massachusetts General Hospital, said, and now is the director of the Centers for Disease Control, said that this form of COVID-19 may be the most infectious respiratory virus she's seen in her professional lifetime. So when we think about where COVID came from, which was Wuhan, China, and where COVID is today, we're dealing with a really different virus, much, much different. We know, for instance, that the virus with the Delta variant, because of the beneficial mutations that COVID has experienced to get to that level, is able to accumulate in concentrations that are over 1,000 times higher than we saw with the original virus. So when people with COVID-19, the Delta variant, cough or breathe hard or yell or scream or whatever, they're distributing droplets and aerosols that may contain, 1,000, actually the number in studies is 1,230 times as much concentration of COVID-19 in those secretions as would have been from the original virus we got from Wuhan. So part of the surge that we experience with the Delta variant is because the inoculum dose is so much higher. And, as we look around West Virginia and look around our country and look around our world, we really are now starting to see 5 or 6 really clear realities. And I think that I will communicate these 5 or 6 things as really the main lessons that I want to communicate during this talk, so that people don't have any, don't get confused by a whole bunch of information that I could potentially share, as Dr. Hill very, very nicely gave me the compliment of communicating clearly. So number one is that in order to see this COVID pandemic move from pandemic, which means everywhere in the world, to epidemic, which means more in certain places, to endemic, which means it's just part of the natural infectious cycles that we'll see, like with other cold viruses, we will need 85 to 90% of our population to be immunologically capable. And right now, if we look at vaccination in West Virginia, we are between 52% of our total population fully vaccinated and about 55% of our vaccine eligible population fully vaccinated. So number one is we are far away from being able to predict and feel comfortable that COVID-19 will be in our rearview mirror, because our vaccination numbers aren't even close to being there yet. And most places in our country and most places in the world, in fact, no place in the world is at that level. And that's a real problem for us, because we are following our reproductive value. And remember, reproductive value is the value that says if one person gets COVID-19, how many people are they likely to infect? And the lower that number is, the better. And our R value at the end of the most recent surge, as we were seeing COVID come down in September and October, we got down as low as 0.83, and now we're at 0.96, I believe. I haven't seen today's number. So we're going in the wrong direction. And that means that we should be very concerned. And if we look at other states in our country, particularly colder weather states like Michigan, Minnesota, Colorado, Alaska, Idaho, they're seeing now more surging. And in places with lower vaccination rate, they're starting to see more hospitalizations. In fact, in parts of Minnesota and in parts of Colorado, they're seeing more people that they saw in some places, even during the most recent surge. And we're also starting to see a bump in rates in New England. In Europe, they're having substantial problems as they loosen their mitigation measures. And in places where it's gotten cold and people are there together, they have started to see a real strong increase in cases, and now increase in hospitalizations and deaths. Okay, I think I saw a question come up, so I'll pause there. That was my number one. Was there a question to answer?
There is. Someone's asking, can you talk about the surge in Europe that's happening right now, and is that a different variant?
So that's a really important question. The Delta variant is basically the variant that is the variant for the entire world right now. You know, we used to read about, oh, there's the Lambda variant, and then we had the Alpha variant, which was the variant from the United Kingdom. But the Delta variant has obliterated all the other variants. And so we are always now watching for something that will dislodge Delta, because that would make us very uncomfortable. But right now, the European outbreak is related to the Delta variant. For many European Union countries, they saw lower vaccination uptake in either their whole population or parts of their population, much as we have seen in the United States. And although for many countries in the UK, in the European Union, they were much more aggressive about maintaining mitigation measures like masks along with their vaccinations. And some countries even require vaccine proof cards, so that if you want to get into a place, you have to demonstrate you've been vaccinated. But because things were looking better in Europe, a lot of those countries relaxed their mitigation measures and let people get back together in big events. And that now, as people have started to go back inside, as the weather's gotten colder, is leading to a reactivation of infection. And it is largely in unvaccinated people, but not solely in unvaccinated people. And that really helps us understand, and I'll get to that as one of my points, but how important it is to get boosted if you're 6 months after either a Pfizer or a Moderna vaccine, or 2 months after a Johnson & Johnson vaccine.
Okay, another question is, can you talk about the safety of vaccination, even for women of childbearing age? Because there are a lot of women concerned about, you know, if they want to have children, how safe is this for them to have? And what I've heard is people talking about, you know, there aren't enough studies, but I don't see it that way. So could you share?
There's a lot of really good data that is both been done and continues to emerge, that basically says that vaccination is spectacularly safe. We know that around the world, 7.5 billion vaccines have been given. In the United States, about 430 million vaccines have been given. And although we do report very rare, you know, complications, effects, we had the blood clotting in younger women with the Johnson & Johnson vaccine, and we saw some heart inflammation in younger men, mostly with the Moderna vaccine. Importantly, with the low dose of the Pfizer vaccine and the studies done in 5 to 11-year-old children, remember the 5 to 11-year-old dose of Pfizer that was just approved by the FDA and the CDC is a third of the concentration of the dose of an adult. 12-year-olds and greater get the adult-sized dose, which is 30 micrograms. The 5 to 11-year-old children's dose is 10 micrograms, and there was no heart problem at all in the Pfizer vaccination in the young people. So I think that certainly these vaccines are incredibly safe and incredibly effective, and lose some potency after 6 months or so, which I'll talk about, but still, I mean, unbelievable. I mean, these vaccines protect people up to, you know, 95% from dying in all the studies, and that really in Johnson & Johnson about 98% 88 to 90%. So these vaccines are all really effective in protecting people from severe consequences and diseases. And a study, I think it was from the VA, no, it was from LA County, said that if you look at vaccinated and unvaccinated people, your risk of dying was 29 times higher if you're unvaccinated versus vaccinated. When it comes to pregnant women, lots of data is out that says that there's no impact on fertility, the ability to get pregnant, miscarriage, the ability to maintain the baby, or problems after delivery with lactation and breastfeeding if you want to do that. And in fact, COVID infection in pregnant women can be a severe disease because pregnant women in many ways are immunocompromised so that they can handle the baby. And we know that the risk of maternal complications, ICU admission, we've put several pregnant moms on ECMO, extracorporeal membrane oxygenation, bedside cardiac bypass, and 2 of those moms didn't make it they died before they saw their baby. And all the moms we've put on that extraordinary life support approach had not been vaccinated. So your risk of getting sick and getting really sick and dying from COVID-19 goes up for women who are pregnant, and your risk of preterm labor, miscarriage is greater with COVID infection. There doesn't seem to be any detrimental impact of getting pregnant, staying pregnant, or having problems with lactation. And in fact, it protects mom, protects baby. So every organization, every medical organization, American Medical Association, the American Society of Obstetrics and Gynecology, et cetera, all say, these women should absolutely get vaccinated and get both doses. It's really important.
Thank you. The next question is, when will the smallest children have an opportunity to receive the vaccination, and what's the timeline on this?
Yeah, those studies are going on. There was some concern that the 5 to 11-year-old population would meet some resistance at the FDA and the CDC because the risk benefit. If you look at 5 to 11-year-olds, about 172 5 to 11-year-olds have died in total everywhere during the COVID-19 pandemic, which is a lot of 5 to 11-year-olds, but when you look at a population level, not a huge number of people, 8,300 hospitalizations, 44% of the MIS-C, the multi-system inflammatory syndrome in children in the 5 to 11-year-olds. But the thought was that CDC, FDA might say, well, the risk to those children is lesser, and therefore, of COVID, so therefore we have to weigh risk and benefits. But that flew by. And I think one of the reasons why the 5 to 11-year-olds were so much accepted by FDA, CDC is because the studies showed the vaccines were really effective, had no real side effects in the vaccine, sore arm or whatever, but that was it. And we know now that children can both catch the Delta variant and spread the Delta variant just as well as adults can, different than previous forms of the virus. And we also know that children 18 and under tend to be more asymptomatic, so harder to detect. So my feeling is because the 5 to 11-year-old got so much support, I know there's ongoing studies in younger kids. They're trying to adjust the dosing for these kids. And that's one reason why it's taken so long, because getting a whole bunch of kids in the study and doing multiple doses is harder. But the anticipation would be that that data should be available by the beginning, I would guess, of 2022. So I would say, early in 2022, you'll hear, late 2021, early 2022, you'll hear more about that.
Thank you. Could you please talk about antibody testing? When's it called for, and what does it tell us?
Yeah, the antibody testing is kind of a morass right now. It's kind of a confusing thing. So we know that when we look at people either who had native COVID infection or who've been immunized, everybody's looking for a way to say, well, how protected are you still? And so antibodies are one way that we measure how protected you are still. But the problem is, we know if you have no antibodies, that's bad. So if you've been vaccinated, you don't have any antibodies, that means that the vaccines didn't work so well, you need more, you need a different strategy. But if you have antibodies, we don't know how low is too low and how high is good enough. because there's no threshold yet. There's been no reproducible studies done that looks at quantitation of antibodies. There was a study in Nature, which is a really high-end scientific magazine, that said that the part of the antibodies you measure that could neutralize the particular COVID virus that you're dealing with is really your immune protection. And remember, when we talk about antibodies, antibodies are like, let's say COVID is like your foot in a sock. So COVID is your foot in a sock, and the antibody is the shoe that goes over your foot and your sock that hides your foot and your sock from being able to be seen by whatever the target is. And so COVID wants to bind to a receptor in your body, and the antibody is like a shoe that covers it up so that it doesn't allow the COVID to bind. So these antibodies are blockers, basically. They block the ability of COVID to get uptaken by your body. And so the more of those kind of antibodies you have, the more immune protected you are. But that, to be able to analyze that, that's really just still a laboratory test. It's not a clinical test. So the truth is that the antibody tests may make you feel better if you have more, relatively speaking, than other people. May make you feel a little bit worse if you have less, relatively speaking, than other people. But whether you have more or less, we don't really know what to do with that. We do know that over time, if you track people and they start losing the immune function, then the antibody, the neutralizing antibody part, the part that is the shoe that covers the COVID sock, that turns out to be more predictive. But whether that's the reason why or just correlates with better immunity or worse immunity, we don't know. So that was a long-winded answer to say, we don't know how to interpret the antibodies. If they're zero, that's a problem. But if you can measure them, we don't know exactly what to do with them.
What I love about the answer is that you prove my point, that you explain things in a way I had never heard the sock analogy. So, so our next question are, some moms are concerned about their daughters getting the shot because of future fertility. Any info on this?
Now, there was a miscommunication, a misperception, a bad narrative, whatever you want to call it, from somebody who said that one of the concerns was that the spike protein, so the COVID virus has really two parts. It has a body, which is like a blob of butter, and then it has spikes, which are like arms that go out from that blob of butter. And the arms are where the virus binds to the cells. I talk about the sock. The sock that you're covering, with the shoe is on the arms of the virus, and those are called the spike proteins. There was a concern that the spike proteins had a resemblance to a protein in the uterus, and that the immune response would hurt the uterus. But in fact, that's been disproven long ago. So even though there is that narrative that still exists in certain circles, I think all of the research that's been done says that there's really no impact of COVID-19 immunization on future fertility. And I would just say that my 27-year-old physician daughter got fully vaccinated and boosted, and my wife and my mom, and so I wouldn't have any concerns about that. I would much more be concerned that COVID-19, getting infected, having long COVID syndrome, or even getting really sick. And even though it's rare for younger people to get really sick, they can do it. And the Delta variant is a different variant. So one of the things that we've seen is, from a hospitalization standpoint, we have seen a big upswing in pediatric cases and young adult cases. And people are sicker with this. So full vaccination, I think, is really important. But the information, the evidence on sterility or the difficulty conceiving, I think has been disproven clearly at the scientific level.
Thank you. The next question. So 2020 data showed that COVID-19 greatly impacted and increased our state's overdose rates. Can you speak about this, and is there any data for 2021 yet?
No, we actually just yesterday were visited by the National Institutes of Health director for the National Institutes of Drug Abuse, Nora Vokow, and we just talked about this. So the data on overdose and death with opioids, particularly with synthetic drugs like fentanyl and carfentanil, have really, really gone up. And it's gone up in West Virginia, but also has gone up around the country. And so this is a really vital time for us not to lose our focus on the real impact, the absolute tragic impact of addiction, overdose, suicide has on young people. And with the synthetic drugs like carfentanil or fentanyl, they're so much more potent than heroin. And they also really, at the doses they give, can sometimes be much harder to reverse with Narcan. You may need multiple doses of Narcan. So we know that the isolation that some people feel from COVID-19 and the stress is certainly likely part of the problems that we're seeing. But interestingly, the movement of drugs in our country has actually also picked up a lot during the COVID pandemic. So that is another pandemic of sorts that we have not been able to get our arms around. And the COVID pandemic, both at the level of distraction that we've been focused on that, maybe not some of the other health issues that we have, and also just, on purely on the resources that we had to put into COVID. Those are resources we haven't been able to put into things like, dealing with the substance use disorder problem in our state.
Thank you. And we also have, for those listening, stay tuned, because the Chief Deputy Attorney General is going to be talking to us about those the opioid information too. So what's the current percentage of West Virginians who've received the booster, and can you mix vaccine brands?
Now, let me talk about the booster, because that's going to be one of my points. That's okay. Point number 2 is 6 months after your 2 shots of Pfizer, Moderna, or 2 months after your shot of Johnson & Johnson, the potency of the protection starts to reduce. So we know that in the country of Israel, they had seen a real substantial change. And at one point in Israeli hospitals, almost 70% of their hospitalized population were fully vaccinated, but they had been vaccinated 5 to 6 months before. And this tended to be older people with other coexisting medical problems. And when Israel went very aggressively and boosted that population, gave them another dose, they're a Pfizer country, then they saw after 10 to 13 days, that really reversed dramatically. And now 70% of their hospitalized people are among the 17% of people not vaccinated in Israel. So we know that boosters are so important. And right now, when we look at our booster doses, let's look at our over 50-year-old population, because we know from before we had the shots, the vaccines, that 97% of our deaths were in West Virginia that were over the age of 50 years old. So when we look at our 50-year-old vaccination group, we have about 550,000 people who have been fully vaccinated in that group, which is about 83% or so, as I remember, of that population. Of that group, we know that totally, let's take that group away for a second, totally, we've given about 50,000 boosters right now. So even among the highest risk group, of 550,000 people, by the counts we have only given 50,000 boosters, which is just extraordinarily less than we need. I mean, so when we talk about an 85 to 90% vaccinated rate, we mean currently immunized, and we then mean that people need to get their boosters. Now, other data from Israel, which I'm really excited about, would say that, so there's always been this concern that the first 2 doses of Pfizer and Moderna, because they're so close together, that maybe the second dose is not really a great booster dose. Maybe they're kind of like a prime dose and another prime dose. And the reason why they put them so close together is because they were so anxious to get to the FDA to get certified that they wanted their studies not to be years in duration by making the booster dose, way after the first dose. But now in Israel, they're getting some early data that says that the booster may last a lot longer. They're measuring people now at 9 and 10 months who were boosted really early. And you may see a better maintenance of antibodies and this neutralizing antibody fraction, because your whole immune system may be more turned on at the memory level, as well as the sort of the active respond immediately level. So there is really encouraging data that getting boosted may give you a much better and more prolonged and much more powerful immune benefit than getting the first 2 doses. And the FDA has shown that in a big study, CDC has shown in a big study that you can mix and match the vaccines safely. And what's really clear is, so if you've had 2 doses of Moderna, the 3rd dose of Moderna, which is half the doses, 50 micrograms instead of 100 micrograms, is really effective at boosting your antibody levels up. If you got 2 doses of Pfizer, a 3rd dose of Pfizer is really effective at boosting your antibodies up. If you cross over and get a Pfizer on top of 2 Modernas, you get a Pfizer booster dose, or if you get 2 Pfizer doses, you get a Moderna booster dose. Those antibodies might go up a little bit more, but generally all in the same range. On the other hand, if you get a J&J dose, you should absolutely get an mRNA booster. So you should get a booster, probably 1 Moderna, 2 Pfizer, and a lesser 3rd J&J, because the study showed that if you get a Moderna shot on top of your first Pfizer dose, your antibody levels went up by 76 times. If you got a Pfizer dose after your first J&J dose, your antibody levels went up 35 times. If you got a J&J booster dose on top of your first J&J dose, your antibodies only went up 4 times. So we would heavily recommend, if you got a first J&J dose, get a second mRNA dose, and I would probably get Moderna personally, just based on that data, but either Moderna or Pfizer, both good. And if you got 2 Pfizer shots or 2 Moderna shots, and if you did well with them, I'd probably just stick with the shot that you got the first 2 with. But if you wanted to mix them and match them, you might get a little bit of a bump in antibodies, and those all seem to be very well tolerated.
Thank you for that good information. And we've got plenty of questions, but I want to stop and make sure you're able to make your points. So I want to see if we knocked you offline, or do you have more points to make before I can?
Yeah, let me make 2 of the points, because I think it's important. So the other 2 points are that we really do want to make sure that people know that during the winter time coming up, which is a really critical time for us, our hospitals were stretched about as much as we possibly could. Please make sure that you're getting your flu shots as well. That's a big deal. Make sure that if you're vulnerable and you're going inside around a lot of people, don't, be hesitant to wear your mask, keep your distance, wash your hands. And if you get any symptoms or get exposed, please get tested, because it's really important. Our hospitals are not going to tolerate a surge in the way that we saw it. We had both the WVU medicine system and the CAMC system operating at crisis standards of care, which means that they are steps away from rationing like we saw, in Alaska and Idaho and Oregon. And we don't want that to happen in West Virginia, but this is a really important time. So that was going to be my 3rd point with winter coming up. And my 4th point is that if you get sick with COVID-19, whether you've been fully vaccinated or not, make sure that you immediately, and you're having symptoms, make sure that you immediately get tested, but also contact your healthcare provider, because using the monoclonal antibody treatment can really make a huge difference, can make the difference between you going to a hospital bed and dying even, if you get them early. And while you can get the monoclonal antibodies up to 10 days after you are defined with COVID-19, they work really better the earlier you give them, because what they do is they're like pre-existing shoes that basically bind to all the socks. So they are ready to go. Your body doesn't have to produce them. You're given these antibodies, and the antibodies can last for up to 3 months. So that really gives you some prolonged protection. And the last point I'll make is, if you followed Colin Powell, who died of COVID-19 despite being fully vaccinated, he was immunocompromised. He was being treated for a cancer. And so in people who are immunocompromised, you may not respond nearly as well to the vaccines as other people will. And so there's new antibody treatments coming on market that have a much longer duration of action. And so there is the potential, and you should pay attention to this, that we may use those preventatively so that we would inject you with the pre-existing antibodies, just like we might inject you with the vaccines. And that may give you a protection for 6 to 9 months. And so that's something that's upcoming. And the other thing that's really important that's upcoming is there's 2 different pill formulations that are coming out for COVID-19, one from Pfizer and one from Merck. And both of them have shown tremendous benefit in people who are infected with COVID-19 as outpatient treatments to keep them from both getting sick enough to be hospitalized and to die. So those are going to be my points, Drema.
Thank you so much, Dr. Marsh, and we certainly enjoyed the interaction and hearing all this, and thank you for sharing your goals for West Virginia and how we can help make those things happen. So we all need to remember that, and we want to wish you a belated happy birthday.
Thank you so much.
From all of us to our favorite Czar, and we appreciate your time. Thank you so much.
Thank you so much for you.
Okay, so someone that I've really grown to admire over the last couple of years and really appreciate his straightforward approach to things and just his kindness as a human being. But anyway, that's Doug Buffington, and for 2.5 years now, he has been the Chief Deputy Attorney General for our state. And so he's here to talk to us, give us an update about what's going on in the Attorney General's office. Thanks, Doug.
Thank you, Drema. It's very nice to be here. Patrick Morrissey, our Attorney General, had planned to be here, and unfortunately the timing of an airplane flight coincided with the timing of his presentation, and so he couldn't quite make it. So I'm standing in his place. A little bit about me. As Drema said, I've been the Chief Deputy for about 2.5 years for the Attorney General's office. Previous to that, I was the General Counsel and Deputy Secretary at the Department of Revenue. Spent a brief stint as an interim director of the lottery, and then stayed on as the Assistant Director for about 9 months over there before coming to work for the Attorney General. We wanted to give you an update on our office and the various things that we are doing. And given that the focus of today's presentations is healthcare, I wanted to talk about a couple of things. Some of our opioid litigation, a lawsuit that we filed on fentanyl, DEA comments, and then some of the outreach that we are doing. So I'll go through some of those things. Before I begin, though, I'll tell you the last year or two has probably been the busiest time that our office has seen, at least since Patrick Morrissey's been in office. With COVID and all the decisions that our governor has had to make, and varying points of view from different people, there have been many lawsuits. There have also been statutes that have been passed that some like, some don't. And so our office has been busy giving guidance, defending when lawsuits happen, filing suit when things are not being done appropriately, especially from a federal level. For example, when the governor made decisions about, initially during COVID, when schools, how to deal with schools and attendance and whether things should be closed, whether counties were red or green or orange, there were many people that disagreed as to his approach and what could happen. And so you had lawsuits about whether schools should be open. Some said they should, some said they shouldn't. You had lawsuits about sporting events and whether they could be played. Sometimes the lawsuit would be about an athlete who's unable to play and is losing their opportunity to show themselves and perhaps get college scholarships. Additionally, there might be teams that were successful all year long and got to the championship or close to it in the playoffs, and then their county turned red. And so there were lawsuits on that. One of the roles of the Attorney General is to defend the state and defend the individual agencies or constitutional officers who are being sued. So we've been very busy with those, working through what needed to be done. As a general rule, the courts have found that the governor has the authority during an emergency situation to take certain actions. It's been pretty universal that the courts have agreed with what the governor has done. And there's extraordinary power that comes with an emergency situation. Sadly, I don't know that anybody envisioned the length of how long these type of emergencies would take place. And those are things that Dr. Marsh and others are dealing with, and they're difficult situations, but those kind of issues have kept us very busy. Moving forward to some of the work we are doing on the medical front or health front, we have been incredibly busy with lawsuits on opioids. Previous to my work here, we had dealt with some lawsuits against distributors in the world of opioids, but we are left with lawsuits against the manufacturers and the pharmacies and their role in what has happened. To take you through a little bit of what we've been doing, West Virginia is the hardest hit state, and I don't think anybody can deny that. We have voiced that concern from the top of the mountain, and we have worked with our sister states in the past year, 2 or 3, trying to come up with fair assessments if money were to come in from various defendants, how that would be distributed. Unfortunately, many of the states, especially bigger states, have come up with formulas that we think unfairly distribute the money that would come in. We think that intensity and how hard a state is hit should be the leading criteria. And while there may be a place for population, it shouldn't be one of the primary considerations, and certainly not the leading consideration. So we have taken umbrage with some of the bigger states, and quite frankly, when we've tried to negotiate, we've been an island amongst either ourselves or a few other states fighting some of the bigger states. Unfortunately, they came up with a plan that we don't think fairly fit West Virginia. And so Patrick Morrissey and the Attorney General's office has taken a very hard line, and we've said no to many of these settlements. To bring you up to date on some of where these are, we run into difficulty with companies that have gone into bankruptcy, because it no longer comes down to whether a state is willing to say yes or no to a settlement. Once they're in bankruptcy, a court will decide, a bankruptcy judge will decide whether a plan is enacted. And the judge has to look at whether it's fair to all states and whether it's treating people equally. And so 2 particular cases, Purdue and Mallinckrodt, are in bankruptcy. And when Purdue went forward, we objected for multiple reasons. One of which I'd like to talk about, is a part of the settlement agreement or bankruptcy plan was to redistribute some of the money to the hardest hit states. And every state agreed to do this with the exception of California. And California said they're bigger. They know that the deal can't go forward without them. They've given enough, and they refused to participate in that. Collectively, the other states agreed and went forward with that plan. We went into bankruptcy court. Patrick Morrissey himself went into bankruptcy court and argued on behalf of the state, and the judge agreed with us. And we have labeled it the California carve-out, but the court pretty much told California to talk with us and talk to others and come back to the court, because they were unlikely to approve that sort of settlement where California gets preferential treatment at the expense of a state like West Virginia. So we were very excited to, basically be 1 against 49 and come out successfully on that issue. And California had to relent and do what we thought was the most fair thing. Now, in a perfect world, would the court say that the whole plan should be changed and more should go to West Virginia? Absolutely. We've argued it. But when you come in with 45, 48, many states pushing for a certain deal, the courts are likely to look at that. There are a few states and creditors that are suing. So in the Purdue pharma bankruptcy, there has been an order, but the court is waiting to move forward until all the appeal issues are heard. With Mallinckrodt, that is not as far along in the bankruptcy process. However, due to the rulings in the Purdue case, California has also relented on the carve-out, California carve-out, as I referred to it. And so West Virginia, being a relatively small state and 1 against 49, has been successful. And I thought it was really incredible to watch Patrick Morrissey personally go up and argue before the bankruptcy court and be successful, despite a lot of big firms and a lot of big states arguing otherwise. So we're really excited about that. Moving forward with some of the other issues, we have been working diligently with the counties and the cities on the opioid crisis. In fact, with Drema to a certain extent, trying to figure out if West Virginia gets money, what we are going to do with it, how is it going to be distributed. So on a smaller scale compared to the national interaction, trying to figure out how states would get money, you have the same complication within the state. Many of the settlements that we have been working require that there be some form of unity amongst the counties and the cities and the state to distribute the money. What the defendants don't want to do is settle with West Virginia only to be sued by Beckley and then Charleston and everybody else. And so they're looking for a way to say, if we come up with the right amount, can we settle with the state in its entirety? And so our office has been working incredibly hard with the cities and counties. Just in the last month or 2 months, we have been on calls and meetings with the cities and counties, working on formulas, trying to derive a way to distribute money that would come in the most fair manner. I can tell you the goal of this office is to give as much as humanly possible to abatement. We're not looking to fund personal issues in our office or anything else. We want as much as possibly could go to the abatement across the state, and that's what we're working with. We think we have at least some form of tentative consensus with some of the cities and counties. Those issues are being worked through, and of course they have to go through the courts, and they have to go through possibly state legislature or various other bodies to get levels of improvement. But we think that if we come to that consensus with the cities and counties, West Virginia speaks with one voice, and it is a strong voice. We think the defendants in the state have heard us. We've been successful in arguments such as the Purdue bankruptcy, and we think the defendants know West Virginia has been the hardest hit. It is the intention of the cities, counties, and state to hopefully speak with that voice and to tell the defendants West Virginia deserves a bigger share of whatever money is coming because we are the hardest hit. We're not going to be ignored. We're not going to be pushed aside just because a big state has power based on their population. So we have been working on that. I will tell you that the state is first up on some of the trials, claims against the manufacturers, which include Johnson & Johnson, Teva, Endo. We have a bench trial set April 4th of 2022. So we will be working towards that unless we have a settlement agreement. That would be on liability issues for public nuisance under our Consumer Protection Act. We also, in September of 2022, have bench trials set against the pharmacies, which include CVS, Rite Aid, Walgreens, and Walmart. And then finally, the cities and counties and hospitals against the wholesalers, manufacturers, and pharmacies have bench trial July 5th of 2022. So it is going to be a very busy summer for our office, for the cities and counties, for the court systems in our state, dealing with these particular issues. I would note one final thing on opioids. When we've settled some of these cases previously, we did something very different than most states. We left open the opportunity for the cities and counties to file their own suits and pursue their own claims. So, when people talk about how much did the state get, we did not settle the entirety of the state's claims. We settled a small portion of the potential claims, leaving open the ability to get more money statewide for abatement that will go across the state to hopefully regions, but cities and counties, and help the people most in need. So that is a big part of the effort that we've had on the opioid front. I will briefly mention a McKinsey settlement. McKinsey is a consulting firm that worked with the pharmaceutical companies, and they essentially, we believe, helped push more drugs into the state of West Virginia and across the country. They were looking for a national settlement to remove themselves from the circumstance, and virtually every state accepted what was being offered. If West Virginia had accepted the offer, we would have gotten roughly $5.7 million. We said no, and we talked to them directly, and we told them we're harder hit, we want more, and we wanted two things. One, we wanted more money, which came to $10 million. Also, we wanted the ability for cities and counties to file their own claims. Only 2 states got that opportunity, Washington State and West Virginia. So our office pushed very hard, rejected the national deal, and continued to fight until we thought we were treated fairly. And that's what we intend to do on all our other opioid matters. Moving forward, want to talk to you a little bit about a fentanyl lawsuit that we filed. It essentially argues that the current administration on a national level, the Biden administration, should stand down from removing the policies about crossing the border and the Stay in Mexico plan. One might ask, what does West Virginia have to do with border control or border crossings? How does that affect us? Well, the reason we filed the lawsuit, and I think Dr. Marsh mentioned fentanyl in the previous administration, we have noticed a massive influx of fentanyl in our state. To that end, Patrick Morrissey and I traveled to meet with some of our prosecutors, our police. We held roundtables and fielded questions. We tried to find out what is going on and what they're seeing on ground level. And interestingly enough, they said fentanyl is becoming a massive problem. And Dr. Marsh talked about the potency of fentanyl. Hopefully my numbers coincide with what he said, but we found that fentanyl can be up to 100 times more potent than morphine. A lethal dose can be as small as 2 milligrams, and a kilogram, which is equivalent to 2.2 pounds, can contain up to 500,000 lethal doses. So what is happening with fentanyl is it is crossing the border. For our state, it seems to go up into Michigan, Detroit area, and then it comes down into West Virginia. It's being laced into fake opioid pills and other drugs, heroin, that are coming into our state that our citizens unfortunately are using and they're dying from. The reason this is happening is because it is cheaper to make and it is more addictive. And so, the people that are selling drugs want an addicted client, so to speak. And if they can find a way to save money, they're going to find a way to save money. The sad reality is people are dying as a result of it. So we looked at what we could do. And so when you talk about people crossing the border from Mexico into the United States, one of the things that's happening is people are carrying over fentanyl and other drugs. It doesn't necessarily mean when there's a wave of people coming through that those individuals are carrying the fentanyl, but when the border control has to move to deal with that wave of people, it opens up windows on the border for bad actors to transport drugs. And they are hiring what are referred to as mules, people that carry drugs across the border in backpacks that are crossing the border. The fentanyl is flowing into the United States and sadly making its way into West Virginia. So we have a lawsuit filed in the Northern District of West Virginia on that issue. We will continue to litigate it. Fortunately, on a similar issue in the state of Texas, they filed a suit, and that policy has been put on hold. The federal government cannot change their policy right now. They have to work through the court system, and we will continue to work on our end in the West Virginia courts, federal courts as well. Another thing I would like to mention is our work with the DEA that we have done. So back in somewhere around 2015, 2016, we were looking at the flow of opioids and the drastic increase in the use of opioids in the state of West Virginia, and looking at why it was happening and what could be done. And we started to understand that there are production quotas, aggregate production quotas that the federal government through the DEA issues to determine how many drugs are appropriate, legal drugs are appropriate to flow into a state. And as probably many of you have seen, it seemed like in years past, there was a pharmacy that popped up every block in West Virginia. And what was the reason for this? It was because so many opioids were being sold legally, but more than the state of West Virginia could possibly consume for proper legal purposes. And so the opioids were coming in, somebody would have a legal prescription, but sadly it was being used for bad reasons and being sold to people and getting on the black market. So we looked at what happened and how the DEA was approving so many drugs to flow into this state, whether it was appropriate. We started writing to them. We started sending FOIAs to them, trying to get answers. Unfortunately, we got stonewalled time and time again, to the point where we said enough is enough, and we filed a lawsuit. Once we filed the lawsuit, things started to happen. The DA started to work with us. The previous administration started to recognize that there was a problem, and they started adjusting their quotas. So luckily, the lawsuit has been successful. And the numbers of opioids that are allowed into our state and across the country have drastically decreased, and they continue to go down each year, constantly being reviewed for whether they are appropriate. So if you have a knee surgery and you need an opioid, you should be able to get that medication, but you shouldn't be able to get it for much longer than you need it. And there shouldn't be so many pills that there's a pharmacy on every block and it's being sold in the black market. Moving forward, we continue each year to look at what their quotas are. We make comments, which is the legal procedure to question what is being done. We work with some of our sister states to review what is being done. And while we think it's much better and we appreciate all the hard work of the DA, we continue to comment and critique and hopefully make it better and better for West Virginia. To that end, we think we've had a great level of success in limiting the number of opioids flowing into our state, which saves lives, quite frankly. So it's something we're very proud of. Moving forward to
Doug, if you have a minute for that.
Absolutely.
Okay, so someone wants to know, do you know when any of the funds would be available for communities? And do you have any ideas about recovery community organizations or other entities, how they'd be able to apply for those funds?
So those answers have not yet been determined. And I presume we're talking about the opioid settlements. We are in the process of working through the court system. There's all kinds of mass litigation panels that have to approve what is going on, how it could be done, if money comes in, what it would look like and how it would be distributed. So I cannot tell anybody definitively when money would be available. What I can tell you is we are working on it every single day. We meet with the courts. We look to have a global settlement. We, as I mentioned previously, have hopefully come up with a plan to work with our cities and counties where we speak with the one voice. And the next step is then to go before Johnson & Johnson or Teva or Endo or any of these companies and say, we speak with this voice, this is what's fair for West Virginia, and then hopefully negotiate a settlement. And then that money would start flowing into the various groups that you referred to. I will say this, though, we are not willing to take a lesser share just to get a settlement. We are going to fight for West Virginia to get its fair share. And so while other states are on board with a global settlement, we continue to fight until they treat West Virginia fairly. But my sincere hope is that it comes soon. I've mentioned the trial dates coming this year, or I'm sorry, 2022. And so usually the way cases work is if there's going to be a settlement, it happens before the trial begins. And so our hope is to get a fair share for West Virginia and not have to go to trial, but we are not afraid to go to trial if they are unwilling to treat West Virginia properly.
Thank you for that. And I just wanted to add that, in working with your office, there is a close relationship between you, the Attorney General, the Office of Drug Control Policy, and the Governor's Advisory Council. So for those who are asking questions about, what will be funded when it comes in and all of that, if you look at that, the Governor's Advisory Council plan, that lets you know the abatement that will be going on whenever the dollars come in. We don't know when that will be, but there is that, commitment by our Attorney General that, we will do the things that need to be done for the people in the communities and who need it and who are suffering. And I surely appreciate that view from your office about that, Doug.
Well, and to follow up on that, I will tell you, as I mentioned earlier, the Attorney General's goal is if he could put 100% of the money into abatement, that's what he wants to do. So our goal is to let this money flow to the people that need it, the facilities that need it, the governmental agencies that need it. Everybody has been affected by this, and we want that money to get to the right people, not just to put a Band-Aid on the problem, but to have a more permanent solution, a more lasting effect on the state. And so that is our goal.
Thank you. Did you have any final points before I kind of interrupted you with the question there?
I'll just tell you briefly that also we do a variety of outreach, and I know we're about out of time, but we do an opioid abuse prevention of the prevention game of the week. That's where we go to a football game, high school football game across the state. We meet with coaches and players. We try and get out information, and we try and highlight the addictive nature of opioids. It can hit athletes. We all think of coal miners perhaps having a bad back and getting hooked on opioids. An athlete could hurt their knee and go get put on opioids and end up addicted. And the stories that we hear are heartbreaking. And so we try to do a little bit of outreach with the athletes and the high schools to catch them early. We do a Kids Kick Opioids public service announcement contest where we ask youth to send in drawings, paintings, stories about how opioids have affected them, and we pick regional winners and statewide winners to highlight the problem that's going on and try and reach the children before this becomes an issue. We had to stop one program during this past year with COVID, but we will restart it. It's an 8th grade student opioid prevention presentation where universities with healthcare degrees come in and mentor and work with 8th grade students to show them the dangers of opioids. One interesting stat is from 2016, but said 15.5% of high school students used a prescription pill without it being prescribed. So we're trying to get to them before this happens, because once you get hooked, it's very hard to get off. And then finally, I would just mention that we are active participant in the National Prescription Drug Take Back Days, where when people have leftover opioids have not been used, instead of flushing them down the toilet or leaving them in a medicine cabinet where maybe somebody could get to them and use them inappropriately, you take them into the proper facility and they dispose of the drugs in a healthy, safe way. And so we're an active leader in that program as well.
Well, thank you so much, Doug. I appreciate your time for coming with us. And we hated that the Attorney General was unable to be here, but we're so glad you filled in so good for him. So thank you so much for your time.
Thank you very much.
I'm going to turn it over to Susie Mullins now, who's going to introduce our next speaker. Susie?
Good morning, everyone. Thank you, Drema, and that was a wonderful presentation. So we are now going to hear from Dr. Mary Rory. Mary is a public health epidemiologist who focuses on infectious and chronic diseases. She's currently the director of the Office of Behavioral Health Equity with the U.S. Department of Health and Human Services at SAMHSA, which is the Substance Abuse Mental Health Service Administration. She's also an adjunct professor at the Catholic University of America and has worked across government, academia, and the private industry. She's worked on 2 components at NIH since 2013 as the program director and officer. At NIH, Dr. Rory was responsible for the health promotion, disease prevention, environmental influences, health disparities, low resources in the IDEA states, and child health portfolio. She's developed a national funding opportunity, overseeing complex budgets, mentored investigators in developing project grants, and disseminated research findings to stakeholders. She previously served as the data lead for the U.S. Department of Health and Human Services Office of Minority Health Committees on the Patient Protection and Affordable Care Act, Healthy People 2020, and Environmental Justice. Her credentials and expertise goes on, but we want Dr. Rory to have all the time she could possibly have to speak with everyone today. So welcome, Dr. Rory, and thank you very much for being here with us today.
All right, so the first thing we want to do is give a great big shout out to the speakers who just left. They were dead on, so let's do that first. I want to give another big shout out to Susie for always inviting me and looping me in. I feel like I'm a part of West Virginia. Can you all hear me? I want to make sure you can hear me. Okay, good. And Drema, thank you so much as well. So I am here and I'm going to tell you quickly a little bit about our office. I don't have myself as together as other speakers who can just talk so eloquently about everything. It's not quite been a year on the job, but let's see if we can get this to work. So I am a part of SAMHSA. We're called the Office of Behavioral Health Equity. You'll hear me say OBE. So OBE means Office of Behavioral Health Equity. And so our vision is to make sure that we work feverishly, if you will, across the country to stamp out behavioral health disparities. That's really our mission. And we want to make sure that everyone is allowed to thrive. Everyone, if it's got a beating heart, it needs to thrive. Even our pets. I have a 17-year-old pug. Now, we're broken up into 5 domains that we run our tiny shop. And right now we're down so many people. We done lost people to the White House for details. It's just me and 2 other people right now, but we're trying to keep it going. So there's a policy, there's a data, there's a quality practice and workforce development, communications, and customer service. Under those domains, policy, we're really looking to promote what SAMHSA does. Right? Whether we get it right or wrong, and sometimes we get it wrong, I'll admit that. We're trying to make those rights, those wrongs right. And then for the data, I cannot tell you all how important the data is. So much so, I'm going to say this to you. If you don't remember anything from today, the best way to move policy, the best way to get Congress to cut you a check is to make sure you have some data. Data is just like location, location, location. You must have data, data, and some more data. We must have the evidence to support our claims. If we say West Virginia needs X amount of dollars, then guess what? You could probably get those X amount of dollars and resources if you have the data. It's so nice to do the right thing, but it's even more powerful when you have both reliable and valid data to support it was the right thing to do. So before we move any further, I just want to make sure if you all don't remember anything else, remember the importance of data. It's really important. And I am biased because I am an epidemiologist, biostatistician by background, so I'm going to always push the data lens. Now, where were we? So we're a policy shop and we're working on data. We're also working on quality practice and workforce development. In that bucket, it's not only to improve the workforce or the diversity or the lack of diversity in the workforce, behavioral health, equity, we have not made it a sexy field to go in. Psychiatrists or social workers or peer educate. We haven't made the field sexy enough for our young people. So I say we start in kindergarten, almost exposing them to what is a social worker. You know how the parents bring in the firemen and the police and the teachers, and we need to bring in some psychiatric counselors. We need to bring in, because if we can start young, I think that we can put a lot more into the preventive efforts of making sure this next generation grows up healthy, free from mental health and substance use disorder issues. Communications. We want to be seen as trust brokers, and I call us the equity advisors of the world, to make sure that as it relates to behavioral health, that we are everywhere at all times, pushing the envelopes that we need to push to make sure that we can keep people safe across the country. And then technical assistance and tons of presentations. I do a whole bunch of them every day. So we have 3 flagship initiatives. One is called the Disparities Impact Statement, and it's really a tool to make sure that the grantees that have discretionary grants at SAMHSA is able to tell us who they're working with and what type of services are they giving them and what are the outcomes. Elevate CBOs is really important, and I would say very relevant to small communities, big solutions here today. We want to make sure we cash in on the unique roles of community-based organizations. They are such that, and I hate to say this, underdogs. They just don't get what they need because they don't have a grant writer, right? Or they just don't get what they need because they don't know such and such or so-and-so, or the grant got a 45 instead of a 10, and a 10 was a perfect score. So we need to knock down those barriers because they are the very ones that actually go out and get the work done. They need more support. And so we have an initiative that we're building basically from the ground up. So far, we've done like a grant 101 workshop. We've done a budget 101 workshop. And guess what we're doing next year? You all don't even have to guess. It's data. We're doing data next year. So we're going to do a series of workshops on why the data has to be in those grant applications so that they can get the grant application funding to support their communities. And then the NED is the National Network to Eliminate Disparities in Behavioral Health. And it's a virtual network. I think we're almost up to about 1,300 community organizations that's focused on mental health and substance use and co-occurring. And what we do there is really special. We not only have like a virtual network where we make sure they get grant announcements, people do blogging. We also have a training that we do on culturally relevant training. And so we'll talk about that in a few slides. And now this is my favorite slide of it all. And you all will get a copy of the slides. So don't take notes. And so on one side, we have the OB flagship initiatives, and then I crosswalk with those domains that I just shared with you. So policy, data, and quality workforce, communication, and technical assistance cut across our 3 flagship programs. And so you can take a look at this. It'll be a quiz at the end and come back to that. So how did the Disparities Impact Statement get started? Well, it was a sectorial priority from HHS to make sure that we capture the information on terms of disparities. So one of the biggest problems with disparities is we don't capture the information. We just say, oh, folks are having a hard time, or they're struggling with this, they're struggling with that, but we don't capture it. We're not collecting the data. If we would collect the data, I believe we would be further along and we wouldn't have to fight as much for funding. The funding would just come and it would flow. And so I think here is why this request was made. Now, why is it so relevant today? It's because it's in President Biden's Executive Order 13985, where we're advancing equity for underserved populations. It's also still relevant. And I'm happy to brag that SAMHSA was the first Office of Minority Health to develop an actual disparities impact statement for their discretionary grant programs. Now, OB's strategic plan is basically to create greater strategic focus on racial, ethnic, LGBTQIA plus rural communities, young people, seniors, incarcerated, anyone that is at a disadvantage. That is our goal. That is our target population. Anyone that is struggling with mental health and substance use disorder or co-occurring. What we're hoping that the Disparities Impact Statement will do is be able to look at access, use, for outcome for racial, ethnic, and all the other populations that I mentioned. We also are looking at a dose response. If we're able to get you all these different services, is your outcomes better than someone that only received the service or someone who didn't receive the services at all? We're also using and leveraging the national class standards. Those are cultural linguistic acceptable standards for behavioral health. And we designed a behavioral health implementation guide with the Office of Minority Health to make sure people would use the standards to help people in a culturally respectful way. For example, if English is not your first language, you should have an interpreter. You shouldn't have to pay for that interpreter, but there should be an interpreter there to make sure that the information that you're trying to convey to the provider is conveyed in the manner that is acceptable. So cultural responsiveness, we all know this because I'm in good company. It's just treating people with the respect that you would want to be treated with. There are a set of 15 action steps. And in fact, I'm presenting a little later today. We're actually giving a webinar on this as well with the Office of Minority Health. And again, it's about receiving the care in a way that is acceptable to you and what you bring to the table. And so that also includes making sure that pamphlets and things of that nature is also in your preferred language. So far, we have looked at the findings that we have gotten from the first set of the Disparities Impact Statement. We're now in the process of upgrading it. We have heard from the grant managers, the program officers, and we now need to update it to Disparities Impact Statement 2.0. Again, Elevate CBO's initiatives. I'm sorry, you all, the pug is waking up. I have a 17-year-old pug, and she's going to wake up. You may hear in the background. I just want to apologize. Now, the Elevate CBO's initiative, again, is to increase capacity for racial and ethnic LGBTQI plus populations. It's also to make sure we connect these community-based organizations with resources. It's also making sure they get in front of SAMHSA's leadership. So in January, we will make sure we'll send an invite out to all the community-based organizations to see if they want to have a conversation with SAMHSA to say, hey, SAMHSA, this is what you're getting right. This is what you're getting wrong. Here's how you can help us move the needle in our communities to rid of the disparities that we're being impacted by. And again, I shared with you, we've already had a grant workshop, Grant 101, that really talked about how to put a successful application together. We also did a budget 101 to also make sure that folks knew that if they're hiring certain people in their applications, that they're able to make sure that they can account for what that person's role is. Another important component is data. And again, for the data, we don't just do it at SAMHSA. We work with all our sister agencies across HHS, Health and Human Services. One that we work really closely with is the Agency for Healthcare Research and Quality. I just proved 319 pages of the upcoming Quality Disparities Report that should be coming out next year. It was not an easy task, but it was done. And so each year we work with them to pull out certain things that we want to highlight that need to get people's attention. And you can see here, we did Blacks experiences fast rising rates of opiate deaths. We did a chart book on healthcare for Asians and Native Hawaiians. And we also did opiate use in the emergency departments. And so those were the things that we worked on last year. We also collaborate with Behavioral Health Statistics and Quality. We call them CBIS. At SAMHSA, they're inside of SAMHSA. We're working with them right now one-on-one to just highlight some disparities amongst the different populations and what we can do to come together, maybe develop funding opportunities that would speak to these gaps. Quality practice and workforce development. Well, that's the NED, and the NED is this great big conglomerate. We work with collaborators. We work with also contractors to get this work done. There's newsletters, there's online spaces to share resources and interventions. There is the best component, I would say, is professional development with NED Learn. And for the NED Learn training model, what we're trying to do is prepare the workforce to handle diverse target populations. And so we have training set up yearly. The trainings go for like 12 weeks. And the final product is they actually have to do a video. So I encourage you all, when you get an opportunity, to click on these links and you'll get to see what they learned from NED Learn. It's amazing. And so that's the good part. Here's the bad part. The bad part is we were able to provide these trainings, but then the community came back and said, we're not able to implement these trainings in our communities because we don't have resources. So this year we're rolling up our sleeves to see if we can get extra money from SAMHSA to give small pilot grants so that they can actually implement the trainings that they learned from the NED Learn program. There are also a series of roundtables that speaks to different needs, basically, again, addressing behavioral health disparities and how do we get to that equity space. There's also, for the first time, we did something called the NED Diversity Inclusion Project Showcase. This is with Region 1. And so we were able to bring all 10 regions together of the country to do some sessions on the Diversity Inclusion Project Showcase. The way that it works is that the community speaks to congresspeople, legislators, leaders of different organizations, NIH, HHS, SAMHSA, to say, you know what? This is what we're doing. This is why our community program is so great. Here's what we need, though, to keep the program great and sustained. How can you help us? The other things that we're responsible for is communications. We collaborate with just about everybody. There's also National Health Observances. We try to celebrate everything every month. This month is National Rural Health Month. It's also American Indian Month. It's making sure that we are really cognizant of celebrating the good and the bad. And so we still have a lot of work to do in all these different communities, but I believe together we'll get there together. The other things that we do, we clear SWIFT controls, and these are controls that go throughout HHS to make sure that behavioral health is at the table. It's like there's health, and we're excited about that, but it's behavioral health. There is no health without behavioral health. And it's not separate. We've got to begin to look at people as a whole person, not one person, but as a whole person that can have multiple problems and issues and needs. And we need to address all of them. And we need to allow them to be at the table to tell us what's most important and where they want to start. Future plans for us? Well, for policy, we want to be able to expand the disparities impact statement. DC government has already contacted me to see if that's something that we could revamp for them and make sure that they could use it. As for the data, we will continue to work on data because that's my passion. I really believe without the data, we cannot push any needles. We cannot see changes, and we can't get funding to sustain those changes. For the workforce, we'll continue to work in the workforce space, but we want to begin to look at how we diversify the workforce. We know right now that African Americans is roughly 10 to 12% of the United States population, but we have anywhere from 2 to 3% that are in behavioral health fields. How do we fix that? We all know that people are able to sustain their treatments and regimens a lot better if they can relate to someone that has their similar experience or background. Not always, but in most cases, the research points it that way. Customer service will continue to ramp up all the things that we need to do for elevate community-based organizations to make sure that community-based organizations get what they need and that these barriers and walls that are up now that stop them for their full growth and potential is no longer an issue. Communications will continue to blog the good and the bad. We need to talk about having those tough conversations about disparities, about racism, about discrimination, about unfairness. And we need to talk about it for everybody. It's not just Blacks or Hispanics, it's poor white rural, it's the elderly, it's everybody. We have to make sure we get everybody to that equity space. And then holistically, equity approach to mental health and substance use disorder. It's just not that I have a problem with my mental health, or it's just not I have a problem with marijuana or alcohol. It's also nutrition, it's exercise, it's sleep, it's dental. The work has already been done by Healthy People 2030. I think we all have to get to a place where we can standardize and do the same thing. Okay, finally, I'll say to you all that our call to action today is to stop it before it starts, right? So these problems that we experience, I believe that our young people are the people that we can best save at this point. Prevention is key. I think to promote resilience in prevention and under-resourced populations, I think that we have to demand that our environments and policies adopt a more resilience in prevention, informed strategies, protocols, approaches with a prevention. And yes, even if prevention doesn't work, we still have treatment, we still have recovery, we still have relapse lens, which assumes that an individual is more likely to have a history of some type of bad experience or trauma. Advocate that it be applied to all facets of behavioral health equity, that there is no health without behavioral health. And finally, together, we can get there together. Biden has written a blank check on equity, and we plan to cash it in. Thank you so much. And I'm happy to stay around and answer any questions.
Thank you so much, Dr. Roary. Sarah and Dr. Mace, does anyone have any questions that are coming in through the Zoom Q&A or chat?
Oh, I'm sorry, Susie. I didn't realize you couldn't see it. So, right now we don't have any questions, but I'm just interested to hear, because I know Dr. Roary has worked a lot in West Virginia. Like you said, you feel like a West Virginian. Can you talk a little bit about the specific projects that you worked with us on?
I can. And I want to give some credit to Jean Bennett, who's the region
Yeah, I love me
regional administrator. Yeah. So I can't. So I would love to take some credit, but I can't like that. So no, through her, I work with her on various projects. The last project that we work on off the top of my head that I can remember was maternal and child health issues. She has this great big wonderful panel. And so there we're lending assistance in terms of if they wanted to work with African Americans, what would be the approach? We know that African American women, regardless of their social and economic status, have the highest rates of preterm, right? Births, right? And we still can't figure it out. We don't know if it's genetic. We don't know if we're ruling out income. So they wanted to create some I don't want to call them pamphlets, but they wanted to create it's not a catalog. What do you call those things? Like a pamphlet, like a catalog, like a guidebook almost for the behavioral health and regular health medical doctor practitioners on how to approach these women and what steps does it take. Is it that they need more childcare? Probably so if they got other children at home, right? Is it that they need to feel respected and not afraid to ask certain questions for things that they're experiencing? So that was the last project that we work on. And before that, it was the NEDS DIPS. So her region also participated in the National Network to Eliminate Behavioral Health Disparities, where they had 3 community organizations come and speak to us about what they're doing, what are some of the barriers and challenges, and how we can work to eliminate that. And hence you have us doing this now annually starting this year, and also making sure we can get small pilot monies from SAMHSA to make sure they can carry out what it is that they need to do for their communities. So there's just a few projects.
Yeah, and can you talk a little bit about whether it's in West Virginia or other states, work in the faith community? Because I know through our African American churches, we're making a lot of, inroads in West Virginia to populations that we wouldn't have probably otherwise had access to. Can you talk a little bit about that?
I can. So now I'm gonna just slide to the side and go back to my other life at NIH. So we have a faith-based HHS organization that works with the faith-based communities across the country. And so at SAMHSA, I'm not sure if we have, I've only been there for 9 months. I'm not sure if we have it, but I will certainly look into it. That's a great point. We learned that the faith-based communities, again, much like the grantees, they really can't go after the grants because the infrastructure is not there. They could be treated almost like a community-based organization and given support. What is really wonderful about partnering with them, as you all are already learning, is they already have the people. They already have the people faithfully coming every Saturday, Sunday, or whatever day it is for them to come and gather. They have the people's interest because they're spiritually connected. And so just one more layer. Yeah, you want to take care of your mental health. You want to stop, abusing drugs. We can help you with all of that. And they don't have to worry about recruitment, retention, tracking, and follow-up. They know exactly where to find them. The way that we can begin to help the faith-based community is by partnering them and making sure that they get the resources they need to make sure that they can get the parishioners there. So that might be food, or it might be pamphlets, or it might be, a $10 gift card or something, but making sure that they have the resources too makes for a successful partnership. And it's almost a controlled population almost. It's right there.
And I'm not sure that some of our listeners may know, but I'm not sure that everybody knows that You know, West Virginia also has, it was the largest population of transgender youth in the country. So that's an area where I know here at the Osteopathic School, we are working a lot with our LGBTQ plus community and our students on issues around transgender. What does SAMHSA have programming and
You better
funding?
believe it. I'm so excited. You see this big old smile on my face. You better believe it. So that I can say, yep, SAMHSA is doing that all day long. Not only so, I'm going to push the envelope and tell you, we make sure we collect data on it. So we're working with CBIS. They just released the data from NISDA, the National Substance Drug Use and Health Survey. They just released it for 2019 and 2020. And so you'll see that there's data on transgender. So our programs are definitely tailored to that and to make sure we collect data. What I'm on them about is making sure we don't leave out the L, the G, the B, the T, the I, and all the other acronyms. We want to make sure we capture everybody. And that's why you saw me highlighting it. Also, we have in the SAMHSA store, we have different communications, pamphlets and resources exactly for this. Also, we have a LGBTQI Center of Excellence. And so that's something else you all, I can share those resources with you all as well. So that's what we have thus far.
That would be great. And I think it's a good time at this presentation to remind folks that, you know, this week is Transgender Day of Remembrance coming up this week.
It is on November 23rd, I believe, that we're gonna celebrate it at SAMHSA on November 23rd, but it's internal to educate the folks at SAMHSA. So
right, that's wonderful, and that's what we're trying to do here too. We've lost so many people, and you know, when hate crimes is a whole other you know, issue around diversity that we all find so abhorrent. But I know SAMHSA has been a big supporter, and Jean has been a great supporter of us, and so I wanted to switch to a little bit of talk about naloxone, because I know that's Susie's heart there too, about some of the initiatives. I don't know if you or Susie either could talk about some of the initiatives that SAMHSA is helping us with around naloxone. I know we've got the nalox boxes and things like that that are coming up. So I don't know if you or Susie want to talk about it, but could one of you share that?
I'm gonna let Susie have it, because I want to just say one thing about it all. We're also rolling out 988 at SAMHSA, and this is going to be similar to the 911, so that when people are now having behavioral health issues or mental health issues, we're not calling the police first, we're calling 988. And 988 is going to help. And the reason why I want to push this is because we did it at the National Academies of Science, Engineer, and Medicine. And I also will send you all that link to review that. We wanted to make sure it speaks to different populations. It's not a one size fit all. So that's the one thing that I think that we will have that connection there with the naloxone. But Susie, please speak to that, please.
Thank you, Dr. Roary, and thank you, Dr. Hill. So yes, we want to make sure that everyone knows about the resources for naloxone in West Virginia. My program that I help shepherd is the West Virginia Collegiate Recovery Network, which is a project of the Alliance. And we are available to do naloxone training in person or virtually. The West Virginia Drug Intervention Institute has a link on their website. It's a self-paced course, and you can receive naloxone through the mail when you take that course. I know that West Virginia did just get a $5 million grant for naloxone, so that's going to help and go a long way. Dr. Akery at the University of Charleston is the person who oversees that grant. So we do have access points to naloxone across the state. So we can put our information in the chat. So if folks have questions about that or interested in training, we're more than glad to do that. I want to give a big shout out to WVSOM, because we have been working with all of the outposts and main campus to help get the medical students trained and equipped with naloxone. So that goes a long way to help them as providers address stigma and provide more equitable treatment, because we know that individuals who are in recovery suffer a lot of stigma, and suffer a lot of stigma even from the helping professions and helping professionals. So that's something that we're working a lot on, as well as is addressing stigma.
Thank you, Susie. And I know here, and so I'd encourage others out there, because I always want to say, from these sessions, we hear them and we love the information, but then how can we turn that around to make it something that's valuable in our communities and things that we can, take from these things to actually implement. And so one of those, I will say, I appreciate Dr. Nimitz greatly for, putting his money where his mouth is and allowing us to do naloxone boxes. So just like an AED, I was very excited about this, and Susie is the one who introduced it to us, but, nalox boxes. So just like an AED on your wall, you also have these nalox boxes. And, I'm old school, so they're modern. You can walk up with your phone and hold it over the QR code, and see, I know what QR code is, and you hold it over the QR code, and then it tells you how to use it. Or for those like me, you can open up the box and it has a card in there that tells you how to use that. And of course, Good Samaritan laws cover people. So, it's better to try and help somebody and keep them alive. And so we're going to have those in our buildings all over campus. And I know you've got several other places, Susie. Can you talk a little bit about that, of the people involved? And if you're out there and you want to be involved in that in your organization or institution, please, get a hold of me or Susie. I'll just refer you to Susie, so you're better to get a hold of her. But can you talk a little bit about that, Susie?
Yes, we're really excited about the Nalox Box initiative. So we're focusing first on the 8 schools that are part of the Collegiate Recovery Network and the other 2 schools that are a part of the Alliance. And then we're also working closely with the West Virginia Drug Intervention Institute to provide for schools that are outside of our network. So we're working directly with individuals on our campuses to get these Nalox boxes placed in strategic high traffic locations, so that if a student, faculty, staff, general public, because our college and universities are such anchors in our communities, and especially our small communities, many bigger events and things happen on our campuses. And so we're not just serving the students, but we're serving the bigger population of the community. So people from all over are coming to our campuses. And just like we need to be prepared to respond to any other type of medical emergency, we need to be prepared to respond to an opioid overdose and, help people survive to get into recovery. So we're really excited to have those boxes. We're just in the process of rolling those out and getting the first ones installed. We hope to have that have the first ones up by the end of the year. So definitely, if we have folks that are working in institutions of higher education, please reach out to me, and we can put my information in the chat as to how to get a hold of me, and we'll be glad to help you with those Nalox boxes as well.
Okay, thank you. And well, Dr. Roary, we so appreciate you coming
to
us. And I just have to use this opportunity to say, having worked with disenfranchised populations my entire public health career, is that, we talk about diversity a lot, and we talk about equity, and we talk about social justice, and those are such important topics. But I just encourage us all to internalize that, and to, realize that, and West Virginia is so good about that. I mean, the people in West Virginia, we take care of each other, we take care of ourselves, and we take care of other people. And so I think it reminds me of what my mother always said, just love people, and the rest of it will work itself out. So I just want to encourage us to think about that, and in our organizations, and if we feel like, that we need some training on diversity, or we need somebody to do some clarification or help us to understand it within our organizations, that we have Dr. Roary here, and she's put some things in the chat. So I encourage people to go in and look at the chat for the information that she has provided for us today. And I just thank you so much. So thank you, Dr. Roary, and thank you, Susie. Appreciate both of your time.
Now, Dr. Hill, before you transition, Sarah had a question in the chat box, and I put my email in the chat box for her, but I just wanted to respond to it really quickly. She said, can you talk a little bit about where integration of behavioral health and primary care fits in the bigger equity picture that you're doing to improve behavioral health in the workforce? And so I just want to give her one example. It'll take me 10 seconds. 700, we have over 700 minority serving institutions across the country. My goal is to tap into those 700 plus minority serving institutions and make sure that there is a school of social work, a school of psychiatry, psychology, that there is something for peer, that there is for counselors, that there is for community health worker, promoters. So that's the first piece. And then the second piece is just what you just brought out, Dr. Hill. We need to live equity inside out. It starts with all of us. We can't get there together unless it starts at home. So it starts with you. And then the other piece is to look at the person as a whole person. Oh, I got mental health issues. Oh, I got no. It's a whole person. And so nutrition and sleep and exercise and dental and all these things are connected to heart disease and stroke. And so if we're taking care of the whole person, we're preventing all that other trauma, right? And then making sure that the person tells us what they think is most important, and then working from that point to get everything else taken care of. And I am happy. That's exactly what we do at work. We have a staff meeting every week. Do you want to know what's on that staff meeting agenda? Equity. Are we equitable to each other? Are we being equitable for the grantees? Are we being that's on the agenda every week. You know what else is on there? Work-life balance. We're no good unless we do just what you say. Take care of ourselves. We're better, we're more productive when we take care of ourselves. So Sarah, thank you for that question. Email me anytime. That invite is out to everybody. It may take me 24 hours, 48 hours to get back to you, but guess what? My personal cell phone is on my email. When you email me, you'll see it. And if I take too long, it tells you to call me. You don't get a response for 48 hours, you should call me. I'm real good with the cell phone. Thank you all. Take care, stay safe, because we have so much work to do. And remember, Biden wrote a blank check on equity, and we're going to do what in West Virginia? Cash it in. All right. Hugs. Stay safe.
Thank
Thank
you.
you so much. Take care.
Thank you so much, Dr. Roary.
Bye-bye.
And I want to mention as we close this session that for those who aren't aware, there is a learning collaborative going on in our state, and it's a collaboration between the 11 of the institutions of higher learning. And we're looking at behavioral health because we know the workforce, we have issues there. So we're working at recruitment, retention. How can we get students into the behavioral health professions and moving that forward. And of course, Dr. Bennett has that we mentioned earlier, has been a great help providing resources for that group as well. So again, great session. Thank you both so much. Now I'm going to just move on to just a few little housekeeping things before we close this part of the day. At 11:15, don't forget this game show giveaway because you need to test your luck, because you could possibly win a $50 gift card. So use the same link that you did yesterday. And this afternoon, we have some great breakout sessions. And so I'm looking forward to that. At 11:30, we'll be doing health equity. At 1 p.m., healthy lifestyles. And at 2:30, the recovery workforce. So we hope you have been enjoying this incredible conference. It was so great yesterday. This morning has just been wonderful. It always just gets me all stirred up, when we talk about all these topics. So I love Health Day, and I appreciate the conference for allowing us to have a full health day.